Good afternoon, ladies and gentlemen. I'm Randy from Faculty of Engineering, Hong Kong U. So on behalf of the faculty, I'd like to welcome you all to the Tech Talk today. So I'd like to pass the time to Professor Kenneth Wong, the moderator. Professor Wong, please.
Okay, good afternoon, everyone. So thanks for coming by. So both on-site and joining virtual that and Zoom. My name is Kenneth. That's Kenneth Wong from Department of Electrical and Electronic Engineering, the department head of EEE. And well, today I'm sure you know why we're here. The Tech Talk is a series of the forums and the dialogues given by engineering researcher of a very diverse academics background to share their insight on innovation to related topics. Today, we have great pleasure to have Dr. Ka-Wai Kwok. I'm sure that you know. So Ka-Wai is where we've been working together for some years. So that's how we're working for technology exchange idea as well. So which fit the title really well today. And so today well, for sure he's a very outstanding researcher. I guess I don't need to read it. We all know that he's a great researcher. And today he's going to share with us a very timely research. Well, I guess if we have that kind of research that may help him during that avoid these kind of accidents that's with a smaller and smarter technology in the robotics area. So without further ado, let's pass the time to Dr. Kwok for sharing with us his insight. Thank you, Kwok.
Okay, thanks very much, Kenneth, introductions. And then it's my pleasure to introduce my research work also regarding the latest development in my research group. So I guess this is the topics, smarter, smaller, softer. I guess the first one maybe draw much of your attention because AI is a very hot topic. And I will try to introduce some more related work. Apart from self-introductions, and I would like to introduce my research group for interventional robotics and imaging system called IRIS. I guess the term is still very unique right now within HKU. So this is my 5 research directions. And from the very beginnings, being an undergraduate student, I learned from robotics, automation, control, intelligent system, genetic algorithm. At that time, we still not yet have the deep learning, just a very thin layer of the neural network. And also moving aside to the application, there's 4 major application-oriented directions involving intra-op image-guided robotics. That means the robotics operation will be performed during the surgery. And also the MR-guided navigation, surgical planning, as well as the soft robotics. So it's my pleasure to introduce the topic, but I would need to also introduce this milestone at the very beginnings because when it's the first robot coming to the world. This is so-called world first surgical robot developed by Professor Brian Davis on orthopedics. This is the first robot. They tried to test it on human, and then try to they successfully removed the human tissue in 1999. I was lucky. I still have some overlap time with Professor Brian Davis. He could be my PhD advisor and thesis examiner at that time. So he introduced a very important concept using the haptics to guide the surgeons to do things in a more accurate manner, particularly for total knee or partial knee replacement. So this video is very self-explanatory and showing the robot is not remote control, remote teleoperate. The surgeons has to hold the instrument and then collaborate with the robotics arm and then provide interaction. And then the robotics arm will guide the surgeons to in terms of the cutting, milling, bone resections, The idea is like drawing a straight line on paper without the ruler. You will spend a lot of cognitive burdens to keep a very focused mind to draw the straight line more or less on the accurate path. But with ruler, it's easy. That robot acting as a ruler, we call virtual fixture or active constraint. So this is the concept proposed at very beginnings for orthopedics. When we turn over to the development on the soft tissue surgery, laparoscopy, so-called keyhole surgery, conventional manual version, this picture, you will know the idea why we call keyhole surgery, because all the instrument passing through to the body has to come channel through a keyhole, one hole. And then the instrument motion manipulation has to follow a pivot point we call remote center of motion. And so what is the challenge? The learning curve is there. Surgeons need to articulate the control manipulation like a chopstick having a pivot at that point. All the motion is got to be reversed, left and right, up and down will totally reversed. So while they do some more sophisticated tasks like suturing, ablation, or dissection, they take time to learn that keyhole surgery. That's why at that times, around after 2000, there's a company called Intuitive Surgical. They have a very well-known prototype, well-known commercial product called Da Vinci. Robotic surgery is no longer a futuristic, no longer on blue sky. Even in Hong Kong, since 2007, I guess more than 5,000 procedures carried out in our Hong Kong hospital already. So this is a very well-known platform. Particularly, they introduced a joint, a robotic joint, degree of freedom called endo-wrist, try to mimic the motion of our human wrist to do things, to do a very high degree of freedom, dexterous procedure, including that kind of prostatectomy, removing the prostate. This is the very well-known one. So in this platform, you will see 4 instruments, including the laparoscope, passing through the trocar, and then you will be able to following the same motion, consistent motion with the instrument. So if your hand is moving left and right, this is exactly consistent to the instrument tip inside the body. So it substantially accelerate the learning curve quite much. But if I stop it here, sorry that I can't introduce too much in terms of a milestone. But if I give out my personal opinions, I would just like to give out the analogy of mobile phone industry. Where are we right now for robotic surgery? It seems to be in the 1980s. The robot can be only perform a narrow specific task. For example, laparoscopy, very expensive. The platform, more than 2 million up to 3 million US dollar. And also the modality, the image modality heavily relies on camera. And not so many patients, they can have a privilege to have that robotics treatment. So along this analogy, we will foresee the upcoming robot. They will take use of more kind of modality. For example, in terms of mobile phones, we have 5G, Wi-Fi, Bluetooth. Not only for dialing phone dialing, you can have a internet browsing. This is after the 1990s. This is exactly the mobile phone development. But we also hope that the surgical robot, can have a more versatile ability, smaller, lighter, less expensive, and also open all to a wider scope of the application. So that's why this is the moment after my PhD graduation. I like to widen my my technology and then try to find another imaging modality rather than camera. So at that time, I aimed at magnetic resonant imaging, so-called MRI. So this is a very versatile imaging modality. Low radiation, you can take many times per year if you can pay for the expensive cost. Also provide a very high contrast image of the soft tissue. The MRI can even visualize the heat map while you're doing the ablation. So this is one example how the brain tumor got ablated, and then the laser fibers deliver to that regions, and then the laser fiber try to deliver some heat energy. So with MRI, you can visualize many things. But the challenges to develop robot under the MRI is difficult. If you just search the keywords MRI accident in Google search, you will find loads of a picture typically like this, having the wheelchair attracted by the ball, very strong magnetic, 1.5 Tesla, 3 Tesla, or although just 1.5 Tesla, this is already the accident. So the challenge is there, but we still aim at having the robot being teleoperate in that extreme environment. This is a typical setting. We want to put the robot inside the donut, having the patient maybe under the GA, general anesthesia, or partially sedated. And we can control the robot out of the MR room. The operator can settle comfortably in the control room, and then through the tunnel, only 1 or 2 tunnels, we call waveguide, we can transfer the signals, transmit the mechanical force to the robot to do things. So actuator robot is a spiritual component of the robot. So having an MI compatible actuator is the key. So we can't use the conventional EM motor, electromagnetic motor, because this is forbidden. You can bring some metal, non-ferromagnetic material inside the MRI room, but that must not be a motor. So in the 2014, we tried to make a prototype, which is so-called pneumatics motor driven by air, pressurized air. Very simple prototypes. We try to prove that kind of motor can be very clean without any EM influence to the imaging, even being operated or static, the image quality is still the same. And even the mechanism is very simple. Inside the hardcore is actually from Lego, the components using the pneumatics. So it was a very I was surprised that draw some good attention from the community. But I can tell you, this is not the very successful story. This is a failure, negative example, because when we look into the air dynamics, look into the motor performance, we find a lot of disadvantage having pneumatics to control it. Although we so-called this is a general purpose motor, continuously giving the rotation bidirectional, clockwise, anti-clockwise. But we found that air is a compassive fluid. That means you can't make the motor control very responsive. And then you've got delay. And then the behavior is not that very linear in between the speed and the power. So this is the kind of bottleneck and difficulties. And then I still remember the time I started this research, extend this research after my postdoc postdoc study, and I hand over this study to my first PhD. At the first year, we aimed at a not science nature, but just an international conference. Suppose, this is a piece of cake. It should be accepted. But unfortunately, I really misled my student, and then finally the paper got rejected. This is a really memorable experience, and I definitely, me myself, also have a best advisor throughout my life, which is so-called wife. And I try to share this problem to my wife. She tell me, why not using hamster animal, and that they could running very fast in the wheel in the cage, and generate a sufficient continuous power to my motor. Yeah, amateur, very amateur opinions, making sounds like making joke to me, but I try to convert it to become more philosophy, and then why not hamster? And I try to pour out why not, and then all the reason here. We expect the motor need to be responsive to the control command, small dimension, size, and then they can provide a steady, continuous force, effective mechanic couplings with the degree of freedoms with the robot, and then also the source, energy source need to be MRI conditional. So this is a kind of questions are very philosophical, and then based on throughout this journey, I asked myself, what is the way out? And then how about hydraulics? Although the impressive of hydraulic actuation is bulky, the potential leakage may not be very suitable for clinical use in MRI. We try to come up a lot of solution and then try to protect the motor and make the motor deal with a very delicate motion, like needle insertions. So this is all the prototypes, driving the needles, putting the robot, orient the needle guide with the scalp mount robot. So this is something we did try. And then we found a killer application after a long discussion with surgeons. Stereotactics neurosurgery, this is a very interesting procedure I can witness. Although the manipulation, surgical manipulation is very simple, just inserting just the needle insertions to the deep brain regions, but it takes 6 hours per needles. And then this procedure somehow, mostly for deep brain stimulation, we need both sides, left and right. So somehow half a day, more than half a day is the typical time. But it's also very interesting procedure, why we so-called complicate, because the patient would not be under the fully anesthetist, and then that has to be partially sedated. If the patient can play the music instrument, they were advised to do it, perform it, and then also they have to make a good response to the surgeons. Why they have to do so? Because they want to know every single step of the insertion, we're going to the right directions, and then ensure that will not affect the other functionality of the brain, like language, motion, motor behavior, and the other very delicate manipulation commanded from the brain. So this is a very tedious procedure, not just only to the surgeons, but also the patient, because during the whole half-day procedure, the patient may be probably being asked by a lot of questions, and then they have to give a very good response. So having MRI would definitely add confidence to the surgeons, because they definitely can pinpoint the target based on the imaging, based on the real-time imaging during the procedure. And then they don't need to trial and error and looking at those microelectronics signals, recordings. So they can trust wholly, entirely on the image. So with the robot, we will foresee the procedure can be simplified without too many iterations. This is some kind of a kind of clinical trial we have done in hospital and try to simulate the surgical workflow. apart from the surgical accuracy. So surgical workflow is very important indicator to demonstrate why we need a robot for this kind of procedure. So this is a so-called robot, although they may not have too many degrees of freedom, but by only just changing the angle, insertion angle of the needles, this is already a very useful things in this kind of procedure. So later on, we try to extend that concept, fluid-driven, fluid-actuated, hydraulic-driven robot. But actually, this is not new. Soft robotics become very popular over the last decade. And then most of them, 90% of the soft robot actually driven by fluid. This is a very interesting prototype from Harvard Engineering School. And they try to pump in the air and then command the robot to change their morphology specifically. But to us, to robotic scientists, robotics is how we think about it. It seems look like just a balloon. Without sensor, without intelligent control, without delicate closed loop actuation, this is just a balloon. And there's a lot of robotics that try to make it more robotics. So again, but the advantage of using robotics, soft robotics, is very clean, safe for MRI. So that's why we like to expand this work and see what kind of application, killer application, particularly for soft robots. So we aimed at the other surgical procedure, which is a transoral laser surgery. The procedure, for example, the tumor somehow will take place in the laryngeal regions close to the vocal muscle. So the procedure is to use a laser to ablate that tumor closing to the critical tissue, like critical nerves or major vessel, or particularly to provide very accurate ablation, not damaging the surrounding muscle. Otherwise, it will induce a permanent effect on your speech, on your swallowing functions. So that's why we need laser. And this is the expected transoral robot setup for MRI robot. So we suppose the patient can be covered by the head coil within the MRI. So not just the bore size of the MRI will confine your design of the robot, also the head coil, because the head coil is another device covering the anatomy to provide a stronger gradient signal to visualize the part more in a higher contrast. So we need to make a very compact robot, and that could be accommodated within the head coil donut. And then the robot will be anchored inside the oral cavity. And the robot has to be soft, provide active bending along the esophagus. And the end effector need to deliver the laser pointer. And that laser pointer will also have another degree of freedom, autonomy. And this is the prototypes. If you come to this room and at the entry, you will also see that working prototype. We put it as a demo inside the glass. So the prototype with providing the active banding, this is a typical endoscopic banding, and very short one. But at the end effector, there's also a laser pointer, but this is not the static. This is a actuate laser pointer. By just inject a very small amount of droplet, 0.002 ml, milliliter, we can drive that laser pointer to project the spot in a very accurate manner. But this is just an open loop control, no sensor at all. And then how we can guide the robot to do a more adaptive manner. That means if the anatomy, if the tumor not on the flat surface, that could be on the 3D geometry, how we can guide the robot to point the laser accurately on the tumor rather than just on the flat 2D plane. We need the closed loop control. We need the closed loop control. This is one of the settings. We try to apply the closed loop control with the laser spot because here the laser pointer can deliver two kinds of laser. One is the visible laser. The other is the ablative laser. For the visible laser, we can take use of that spot to close the control loop to provide a visual surveying control so that by having that non-invasive visible laser, we can guide the projection very well. So, but where is the camera? The camera can be a fiber scope, also compatible with the MRI scanner. So this is the camera view. So based on that very rough camera view, we try to do a kind of test in the cadaveric trial, in the cadaveric subjects. And we put the robot anchor on the mouth with the tissue tongue retractions and then going through the tunnel. And then you will see the laser spot doing the job, try to prescribe. The trajectory is prescribed by the surgeons, the operator. With the same times, we have the MRI thermometry. This is the heat map, can obtain real time from the MRI. We can understand very well, monitor the heat very well. Looking at those heat diffusion, we will be ensure no surrounding healthy tissue will be damaged based on that settings. So you can see the heat map here captured by the MRI images. And then before and after the ablation, you can have a very nice, good, comprehensive post-procedure evaluations. So, but here we are just using a camera as a sensor. If I say, if we want to move on to robotics advances, what can we do? How about sensor? Can we have some more sensing modality to obtain the real-time morphology of this robot? Optical fiber is definitely the choice. That's why I also introduced Kenneth to say something during our Q&A sessions. This technology is an old school one, originated in 1980s. Basically, just a fibers. We grate some things along the fibers. The grating itself will reflect a particular wavelength back to the console. So by pressing the fiber, giving some strain changes on the fiber, stress on the fiber, you would know the strain details. That is a simple idea. We put the strain gauge on the fibers. So every single point on the fiber will become a continuous strain gauge. And here is a very interesting prototype. We extend the application to be a soft robotic skin. Just a A4 size of rubber, very thin rubber, without any electronics, combined with AI. With that very raw strain gauge information, how we can recover, reconstruct the strain gauge data, become an entire big scale morphology in A4 size. So this is a kind of test. We did it also in HKU, and then we try to test how fast can the optical fiber can sensing. So we fire a lot of bullet, and then you can see that robotic skin actually can capture a very continuous, high sampling rate sensing morphology. So this is a kind of test, a very interesting one, without using any flexible electronics, very sophisticated fabrication method, and no electrode at all. So this is very good to us for MRI guided robotics. Even can put it into water to measure a kind of a very cyber fish fin interaction with the water. So we try to also look at this multiple core fiber. So that means one single fiber, we have multiple channels of strain gauge, FBG. And then based on those models, we even can reconstruct the 3D curve in real time. So you will see this is the fibers in my laboratory. My colleagues try to change the different curvature, and then the measurements is very good. What is the application? What kind of surgical instrument will involve that morphology? Very straightforward thinking. Catheter, cardiac catheter. This is a procedure called cardiac electrophysiology. So in Hong Kong, we have a lot of similar procedure. The idea is that the surgeons, the operator has to channel the catheter from the femoral vein up to the heart chamber, and then make a puncture, and then try to go through somewhere to the left atrium, or even further down to the left ventricle. And the objective is to make some scar, ablate part of the tissue, so as to that scar and tissue will become the blockage, the boundary on the abnormal electricity. That abnormal electricity will make the heart motion very irregular. So the disease is called heart rhythm disorder, or arrhythmias. And this is a kind of application we try to combine two tracking together. One is the FBG shape tracking plus the MRI tracking. We have to incorporate some marker on the catheters. And this is a robot. We put it in the MR environment, and then we try to do some tests. The phantom is no longer static. You can see the pulsating blood flow going through the left atrium, and then the control is the AI-based control doing a very good job without any prior knowledge of the kinematics. We don't know the material of the catheter. We don't know the bending characteristic of the catheter, but just by learning, by demonstration, we know how to control the catheter under that kind of high frequency sensing data, tracking data. So if I stop it here, you may think, oh, MRI guided procedure is good, very cool. But it may take time to absorb the technology, because right now we don't have so many sites. They got the intra-op MRI facility. And how my technology can extend it to another type of minimally invasive surgery. I can give you one example: interventional endoscopy. So this is a kind of procedure I spend a lot of time to investigate, and I hope in the upcoming future you will see a lot of new technology that could appear in these surgical paradigms. So this is the endoscope. You may be more familiar, like always in black color. I don't know why. Like a slick sticking inside to the bodies, but actually not slicking. The term is misleading. Actually, the surgeons try to maneuver the joystick handle, and then he has to push it, the scope through the mouth, through the anus, through the lateral orifice entry. And what it can do, mostly for, let me use an example in gastrointestinal tract, GI tract. So this is a typical instrument, not so many dexterity provided. The instrument like a grasper to perform a tissue retraction, lift it up, and then try to extend another instrument from the working channel of the scope itself, and then do the ablation. So this is already a kind of procedure can be carried out under the endoscopic platform, but the demands is there. Loads of disease occurred in Asia. We have a lot of early stage tumor, and then that's why already have a lot of promotion from the government. If you are above 50, you are strongly encouraged to regularly do the screening on the stomach or colon. Colonoscopy is always somehow included in many medical insurance. But if even we can screen it, how we can apply surgery or apply more therapeutics procedure on it, which is very challenging. I can tell you the working channel is 2.8. So that means your instrument need to be less than 2.8 or 3.7 millimeters in terms of the diameters, and much smaller than the Da Vinci robot you just saw. And the mechanical challenges is that I use the analogy puppet. If you want a wooden puppet dance, walk, run with a higher autonomy, you need more and more strength to link it up with every single joint. Similarly, if you want to have a robot arm, that has to be flexible, channel along the endoscope, and then that robotics arm need to be less than 2.8 millimeters, and then more and more tendon need to be involved along that flexible route. The challenges is here, how you can decouple those mechanical transmission very well, make all the degree of freedoms independent, and then try to how you can make the force transmission in a very efficient manner. So if you look at the commercial landscape, I try to decouple into 2 dimensions. One is rigid, vertically rigid and flexible. The other dimension horizontally, which is the thickness of the instrument. You will see a loads of instrument, commercial one, they are laying down below towards the rigidity. And then very last, they can provide a fully flexibility channel along the endoscope. This is exactly the gap. Although some of them may be successfully perform less than around 4 millimeters, but still not enough for the conventional one. So we are hoping to fill in that gap. And then I need to thanks for the technology transfer office in HKU. We successfully spin off the company called Actuators Robotics, and then specifically deal with that problem, making a very thin, small robotics arm that could transfer along the conventional standard endoscope. So maybe I would like to sum up here. And the last but not least, I have to thank for all my teamwork, also the clinical partners in different hospitals, and also my research colleagues in my research group. Thank you very much.